Welcome to another episode of Cutting Edge Health. Today, we are talking about, does side matter? We are talking about right or left-sided stellate ganglion blockade for PTSD and how impactful it could be and whether one side or the other, or maybe even both, might be the best solution for you. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician that helps patients understand their options for not only pain relief, whether it's physical, but also if it's emotional, and how to be able to look at those two, how they integrate, how to be able to separate, and how to be able to make sure that you get back to leading the life you deserve. Today, we're talking about PTSD, and we've talked about this before, but we're rehashing this because this is pretty darn important. At the end of the day, there's different ways that people experience post-traumatic stress disorder. They can experience it in ways about avoiding trauma, not wanting to talk about it, them being easily frightened, them being in a negative mood, negative thinking, avoiding certain places, certain activities, having flashbacks, loss of interest, feelings of guilt, using different substances in order to be able to make it through, and things like sleeping difficulty. We know that's the case. It's incredibly difficult to treat, whether that's medicinally or through therapy. However, stellate ganglion blockade has come on as of late, actually for a little bit of time now, in terms of it being able to intervene. So when we take a look at this, stellate ganglion has been around actually for decades, but in terms of it being used for depression, it was started to be utilized in the 1940s. But where it really became into vogue was the 1990s, which has been a while now, but it has been utilized for PTSD in order to be able to improve symptoms. How it was initially was found was utilizing it in the context of being able to help for pain, and accordingly, it was helping people with trauma. And we're going to talk about that in a little bit more depth and detail. But there's certain parts of the brain that we believe it's mostly related to in terms of the aspect of PTSD. And those different parts are the following. So we think about that aspect of the amygdala, the hypothalamus, and insula. We're going to come back to that. I know it's a lot of fancy terminology right now, but we're going to break it down so that you can be able to understand and that you get it, and so that you understand how this is going to all connect. So when we talk about this, what are the different parts of the brain and how do they really interrelate? So the different parts of the brain, like when we look at the aspect of prefrontal cortex, we think about how it affects personality, how it affects how we plan and problem solve. We look at the hippocampus, it's about memory and aspects of learning. And we look at the amygdala, it's emotional memories, how it regulates our body and behavior, and how it initiates responses to fear. So these areas are all interconnected, and PTSD can really rev these areas up and sometimes go differently than what we expect. So how does that play itself out when we look at how these things kind of function? Well, stress can cause this post-traumatic disorder, and it can result in a number of different things, including challenges with traditional chronic diseases, which we don't normally think about, which are diabetes and cardiovascular disease. And although that's not the nature of our talk today, we'll kind of give you a little bit of a key and clue to that, and that is it changes peripheral inflammation, or at least so we believe that's the case, which can cause some of those things to be worse. In addition, one of the things that we know is that there's an increase in sympathetic activity. That's green box over there on the right-hand side, which ends up resulting in damage. And we can also see increase in inflammatory markers. Why is this important? Because it has a number of different effects, both from a mental health standpoint as well as from a physical standpoint. But let's back up a little bit. You guys may have seen some of the lectures that talked about how a stellate ganglion block is done, but we're going to give you further information, show it to you, and then talk about what's the benefits of one side versus the other side, what's more commonly done versus not. If you had to take a guess, what side do you think is more commonly done? Maybe put that in comments below if you're watching this live on YouTube. And this is a picture of the neck, which is where the stellate ganglion is housed. As you can see here, you can see the areas of the aspect of the skeletal cervical spine. In front of it, you can see the trachea, and off to the side, you can see various different muscles. It's hard to differentiate in this picture, but there's also blood vessels that are present there, as well as the brachial plexus that sits in between those muscles. in and around that area is where we actually find the stellate. So when we cut away from some of those muscles and look a little bit deeper, it looks like this. What we can see is these labeling of the C1, which is the cervical vertebral body, number one, C2, C3, C4. Again, we see that aspect of the larynx and the trachea. And then here we can see those nerves or collection of nerves that come together. And you can see something that's called the middle cervical ganglia. And you can see at this very bottom down here on the left-hand side, the cervical thoracic stellate ganglion, right? And so that's the area that we're trying to target. But there's some nuance to that of how it's dealt with and how it needs to be looked at. And one of the main reasons is because there are important structures there in addition to the nerve, specifically blood vessels. So here we can see that area of that vertebral artery as we cut away deeper. We can see the area of this chain of nerve, which is kind of this orangish / mottled color that's there, and it wrapping around various different vessels. So although the stellate ganglion sits in and around the areas of C7 and T1 to an extent, it's seldom that we put a needle there. And one of the main differentiations of why that's the case is if you look at C6, you can see there's a portion of bone that sits in and around there that protects us from getting around the vertebral artery. And so if we were to kind of take a look at this from a live portion, it looks kind of the following ilk. So let's say we were to take a look at this skeletal model and we were to say, okay, this is our area and our region. What we're looking to do is to be able to place a needle in various different areas. And we're going to talk about why we pick C6 and actually nowadays why we also pick C4. Both of these two areas have reasons and rationales, but there's also a component of when we look at the utility of doing something like the other side, there's a reason for why we do it and what's the impact of it accordingly. So when we look at this, one of the things that we see is that traditionally, when you get this treatment that's present at the C7, C6 area, you end up resulting in something that's called a Horner syndrome, which I'm going to show you a picture of, which is really kind of a good positive side effect, basically saying we've gotten to the area that targets that nerve and those nerves that are associated with the areas that go up to the brain. What is this again related to? It's related to the sympathetic activity. And what we're basically doing is calming down the sympathetic component. So what does that mean? What that means is the following. When we think about sympathetic, the best way to kind of describe this is this fight or flight. So you have a saber-toothed tiger that's about to come here and eat you as an ancient caveman. What you're really revved up is like, how can I either run or how do I protect myself? And so your heart rate elevates. You feel this stressful situation. You have various different catecholamines and other pressors that are present, right? But think about you having that same experience because you're having a flashback for more than likely a probably really negative, bad experience in your life. And you're having this repetitively and you can't control it. That's what we're talking about when we're having PTSD. And what we're utilizing in order to be able to improve this is this treatment that says, calm down nerves, calm down. And there's different ways to be able to treat it. But in essence, we treat those nerves and then we can see on the outside, you have something that's called a Horner syndrome. So what does that look like? It looks like the following. So on the right-hand side is normal. On the left-hand side of this picture is what happens with the Horner. What you end up seeing is the eyelid droops a little bit. It comes back to normal eventually, and you can see it's a little bit more red and injected. And so that is what happens when we stop the areas of it being sympathetic activated, right? And so what that means is normally when you have that saber-toothed tiger coming, your eyelids are going to be wide, your iris is going to be wide because you need to see where it's coming from. Right? Versus when you're much more relaxed, you can see that relaxation that takes place. And so that's one of the ways that your body responds when we've gotten a stellate ganglion correct. As we've looked at this over time, particularly within the last 10 years, there have been two docs who've been actually the leaders in this field. One is a Dr. Mulvaney, and the second is a Dr. Lipov. Fortunately, I've been able to meet both of them. Phenomenal doctors have really been able to push this science and help people for particularly our first responders and our veterans. But they have been instrumental in making and being able to define that literature. And this second paper that we're about to describe here is from Mulvaney, who looked at doing a stellate with not just focusing on one area and region alone, but looked at doing it, as I alluded to earlier, at C6 and C4. So again, the reason why we're doing it at C6 is because it's the protected area. It doesn't let us get into that vertebral artery and nerve. And C4 is a little bit higher up. It's an aspect of one of those cervical regions that we talked about before. That's the cervical sympathetic trunk. And when it's done in that fashion, when you're able to get two different spots, which there's a technique and skill set to being able to do that, you can see the success rate, which we're going to talk about in a little bit, and how that responds. So one of the papers that has been put off, you look at the first name over here on the first left, that's Dr. Mulvaney, and the name on the far right is Dr. Lipoff, where they looked at 166 patients that had PTSD. And what they were able to see in this aspect of the paper is that those who were treated, 70% of them treated with a right-sided, this is where we start coming to the sides here, of a C6 treatment, had significant relief that lasted them anywhere from 3 to 6 months for an injection that takes maybe all of 10 to 15 minutes to do. In addition, being able to do a second treatment also was able to give sustainable relief and be able to ablate that response. So what does that end up resulting in? That summation is that 70% of patients got improvement that lasts anywhere from 3 to 6 months in terms of duration, which is significant because PTSD is incredibly difficult to treat. So how does it work? And this is where things get a little bit more complicated. They get a little bit more science-y involved, if you would. And I know that that can be a little bit intimidating, but at the end of the day, we're going to make this science fun. So what it states is that this initial postulation is that the sympathetic activity that has this degree of peripheral vasodilatation that occurs, that basically when we are able to use stellate ganglion blockade, it changes something that's called nerve growth factor. And it also is able to make that inflammation better, the sympathetic activity better, and those things that cause us to be revved up, if you would, to be reduced. So there's a different paper that looked at left-sided stellate ganglion and how those patients may respond when a right side seems to fail. And it's a 205 patient analysis, which is a pretty significant number. Again, you can see Dr. Mulvaney as a reference to this. So traditionally, there's reasons for why we do right-sided, and just kind of getting down to the nitty-gritty of it. There's certain structures that are present on the left side that can be problematic if we get into it or we don't avoid it appropriately, while the right side traditionally doesn't have that. But there's other reasons for it too, or at least there's speculations to it. So normally we do a right side, and in this particular paper, what they saw was the following. Is you can kind of see this graph. This RGSB stands for right side. If you skip down to the third balloon, it says LSGB, which stands for left side. So of 205 patients that were treated, the vast majority of them responded, almost all of them. However, about 20 of them in this particular paper didn't respond. So they talked to them and said, hey, what if we did the other side? Would you be willing to do it? And of those 20, 9 of them said no for whatever reason. In the paper, it goes into depth and detail about it, but there's not some significant major reason for it. So they had another 11 patients. Of those 11 patients, they treated them. One of them, they were not able to follow up with, meaning they weren't able to get further information after the initial treatment. So that left them with 10. Of those 10 patients, 9 of them responded and only 1 didn't respond. So what does that mean in significance is that those people who get treated with the right side, for the vast majority of them, they work. And then of those who get treated with the left side, who aren't responding to the right, they typically work on the left-hand side. So what they basically found is that 90% of patients responded to the left side if they didn't respond to the right. And so overall, they basically were able to show that only about 4.4% or less than 5% did not respond. And they did have a response to a left-sided stellate ganglion blockade. So the question most people would ask is, yeah, okay, I get it, but why? And that's where things get way more complex. There's no true definitive answer on that, but there's 2 different papers that attempt to try to solve it. The first shows this. They basically state that what they think is the right side may fail to significantly improve post-traumatic stress disorder, and they think that maybe it's secondary to how there's a variation in the autonomic network, right? And so when we go into detail about that, is one of the things they look at is that right side may have more of a predominance with dealing with sympathetic activity, and the left side may have more of a significance dealing with the parasympathetic. And those areas may be associated with different portions of the brain. If you recall, originally I gave you a picture that showed this region that looks like this. We talk about the insula and amygdala. When we kind of come back to this and we look at this in a different way, one of the things that they postulate is the following, is that at the end of the day, we need balance. But if you look at this area over here, which is the very first bubble with the orange, is that there's a right-sided symmetry, that there's a sympathetic activity, which is just really just all out of proportion. And you treat the right side and you're able to get some degree of benefit. However, there may be that the left side, on the opposite side that we treat secondarily, it may not be enough. And so we need to kind of reset it and get it back to it functioning. But what this paper goes on to postulate further is that the following, is that in essence, you may have this right side that might need help. You may have a left side that needs help, but it's a possibility that you might need both, which I kind of alluded to before. So you could be right dominant, you could be left dominant, and you may be asymmetrical. So at the end of the day, most patients respond to a right-sided stellate ganglion blockade. But for those who don't, there's a way to be able to do it on the left side. Traditionally, when we're doing this in our practice, we're going to do that C4, C6 that was talked about before in order to be able to get that degree of response. And so normally we're going to treat that right side, get a good response to it, and be able to improve someone's overall health. And then if that doesn't work, we can talk about doing a left side and see how that is able to give benefit. Hopefully, this video was helpful for you. It gave you some new insights in terms of PTSD, what the areas that are influential, both from a nerve standpoint as well as a brain standpoint, and how you can really be able to have options that seldom are talked about. Really appreciate you joining, whether it was live or afterwards. If you have questions or comments, please leave them below. If this is a video that you found interesting, please subscribe to the channel, and thank you so much. And hopefully this helps give you insight about how to punch pain in the face, whether it's emotional or physical, and get back to leading the life that you deserve. Thank you so much and have a great day.